Hello, students. Good evening. From where we are streaming, there would be a lag of some around few seconds. Let us just see whether we are live or not, and am I visible and audible to all of you. And also would like to check if the chat box is working properly or not. Yes, I think we are live now. Yes, Nikki, Abhishek, Malhotra. Yes, very good. I can see you in the chat box. I can see your messages. Okay, so that's great. And we are live. Okay. Yes. So welcome all of you to our session. And what are we going to do over here? Just a couple of things before we begin. Okay, so all of you know about the Unacademy NEET PG initiative. Absolutely very important for your PG entrance preparation as well as MBBS, and lots of successful rankers in the NEET PG examination, and you should join the next batch which is started already 26th March, and the promo code is mentor, MENTOR. Mentor is the code to get the discounts as well as your discounts, and MENTOR. Okay, we are here to personally guide you, mentor you, all of you, so you will get the best teachers and the best knowledge. Okay, and this is what we are here for. The IPL cricket season is on, so 2020 top 20 topics. Okay, this is the list. I'm sure all of you must have attended the previous lectures by the previous teachers, Dr. Shanmupriya, Preeti Sharma, and I am here. And one more very important announcement again tomorrow at the same time. Okay, so we are going to, today is 7th of April, and again tomorrow also please join in at the same time, so that all of you can hear one more very good lecture, because as you know there are two subjects. So today I am going to discuss about gynecology. Okay, gynac is today, and obstetric MCQs will be coming tomorrow. Okay, so 20, so around 10 topics in gynecology and 10 topics in obstetrics, that will make it T20. So tomorrow same place same time, again on the YouTube, free for all, 8th April, tomorrow at 6 p.m. also we will meet. Okay, and lots of other things are there for you. Just a second. Yes, so you can go in and join the pathology and microbiology lecture by Dr. Preeti Sharma at a very good price. Again, the code remains the same, mentor, and FMGE students also can join, where all the best teachers are going to take the lectures for all of you. The code remains the same for all of you. Okay, and this is very important, students. I want you to make a note of this. NEET PG Vitals, they are superb lectures, completely pre-recorded lectures, and this offer is till 8th of April. Please make the maximum out of it, where you are getting extension plus notes of 7,500 completely free on 6 months and 18 months subscription. This is completely NEET PG Vitals. They are pre-recorded lectures, plus of course live will continue, plus printed notes, and of course the code is the same to get it, mentor. Okay, is it clear to all of you? Yes, and the next PG batch also has already started, and 9 months combo package only at a highly discounted price. Code remains the same, mentor. Okay, so all this rest, all the things you know, what are the advantages. You get live lectures, recorded classes anytime, anywhere, as per your convenience, and any device of your choice. Okay, so with this iconic subscription also available, and the special feature of the class already, you know, poll, raise the hand, and never miss a lecture, and of course you can ask directly the questions to us. Okay, so with this, just remember the code mentor and download the Unacademy app to get in all the information. And as I said, don't please forget about the Vitals. Okay, Vitals is extremely superb lectures, completely pre-recorded lectures. All of you should see the demo videos and enroll in the Vitals as soon as possible. Okay, so let us begin the T20 season with our top 20. So why this concept came was the top 10 topics. Okay, so top 10 topics which are there, 20 topics we are going to discuss over a span of 2 days. Okay, 20 topics, 10 topics in gynecology. By those 10 topics, I will be telling you which all topics will be there in gynecology, which are very important from the exam point of view, like your fibroids, cancers, hormonal imbalance, amenorrhea, menorrhagia, infertility, contraception. So all these 10 topic MCQs we are going to discuss. There might be 2 MCQs in each topic. So we're going to discuss almost more than 15 MCQs we're going to discuss in a span of next 70-80 minutes. So stay right till the very end, and all of you please participate in the chat box. And tomorrow we will be coming up with the 10 top obstetric topics, like your Down syndrome, triple marker, APH, PPH, forceps, instrument, all the pre-eclampsia, all those MCQs will be coming in tomorrow. Okay, so with this as the background, and I've told you please come in tomorrow also at the same time, Saturday, 6 p.m. for the lecture. Okay, so let us start the discussion. And the first topic, anybody? Yes. So this is a very, very important MCQ, version MCQ, likely for the future exams. Yes, this is for INI-CET as well as for all the upcoming exams. So anybody? So what is this showing you? They have said that a 26-year-old infertile patient has undergone a HSG. This HSG image going to. What is the next step to be done? Anybody? All of you. I've got 5 options for you. Do I do ovulation prediction with IUI, IVF, repeat HSG, laparoscopy, and wait and watch? Anybody? All of you please answer in the chat box. Right, wrong does not matter. Okay, Abhishek, D. Okay, so now anybody, can you first tell me what is the diagnosis? What is the diagnosis? And why many are telling B? Anybody? What is the HSG diagnosis? If you look at this picture, what is it showing you? Okay, so what it is showing me is, all of you please pay attention. This, anybody, which is this? Can all of you see this instrument over here? What is this instrument? This also is an MCQ. All of you know that with my style of teaching, with one MCQ I don't discuss one MCQ, we discuss 10 other MCQ. Yes or no? Yes. So this is the Leach Wilkinson cannula or the Colvin's cannula. Very good, excellent, all of you. Yes, no, but that's not Carmen. Okay, yes, and perfectly correct, all of you. I'll just show you. But this is a difficult, extremely difficult PG level MCQ. All of you pay attention. Very well, sir. Uterus can be seen. I'm drawing the outline. Uterus is being seen. But what about the fallopian tube? Yes, sir. I should have seen the fallopian tube over here, and I should have seen the spill of the dye. So the fallopian tubes are not seen at all. Okay. Fallopian tubes are not seen at all in this picture. Okay, only the uterus is being seen. As all of you can see, the fallopian tube is missing. So it is, yes, the first impression which we get is that, sir, it is a very good, as Dr. Mahmudul Hasan, all of you, Indranath Roy, that, sir, it is a bilateral cornual block. But can anybody tell me any other diagnosis also? So one is that, sir, both the tubes bilateral cornu, I'm writing C level pe cornual block. Okay, at the cornu itself you can see that cornu ke aage, so it is a cornual block. Agreed. But anything else? Okay, so remember, students, if you want to get a gold medal in your final year exam, when you see this picture, it is not only a cornual block, it could also be a cornual spasm. Now anybody, what is the difference between a spasm and a block? Yes, very good, Nimra Adhoni. No, beta, fibroid nahi beta, Devdatta Panda, fibroid kidhar hai? Okay, there is no fibroid in this picture. Uterus is absolutely nice, clean, fibroid is not there. Okay, yes, so please understand this. Point number 1, let us look at the options. Why I can't do IUI? Why option number 1 is out? IUI is out because for IUI, what is IUI? There's a next MCQ we're going to discuss. For IUI, the fallopian tubes have to be open. We never repeat the hysteroscopy. No point repeating the hysteroscopy because hysteroscopy is the initial test. If it's showing any abnormality, I need to go and confirm it. How? I'll tell you. Again, you can't just do wait and watch. Okay, so many of you are confused between B and D, and many of you told me B has the answer, which is wrong. Why B is wrong? Because IVF is the last option. I first need to really confirm whether there is actually a block or not. Yes, when do I do IVF? When both the tubes are blocked. Okay, when both the tubes are blocked, then we have to go for IVF, but I need to confirm actually whether both the tubes are blocked or not. And that is the differential of this, that sir, whenever you see only this picture, you have to say, sir, I would like to give a differential diagnosis. It could be a bilateral cornual block, or it could be a spasm. Spasm is a temporary, thank you Rishiraj for your words of appreciation. Yes, so spasm is a temporary smooth muscle contraction. What is a spasm, anybody? And what is the treatment for spasm? Spasm does not require any treatment. Spasm is a temporary smooth muscle contraction. Spasm opens up on its own, because while we are pushing the dye, the tubes can undergo a spasm. So whether it's an actual block or a spasm, I will come to know only when I do a laparoscopy. So whenever there is any abnormality on the HSG, please do the laparoscopy. And since you are anyway doing a surgery, we'll also put in a telescope inside the uterus and do a side-by-side hysteroscopy. So laparoscopy is what is required. Is this understood? Why? To confirm. Is this clear to all of you? So the answer is option number D. Laparoscopy will be done to find out whether there is actually a block or there is a spasm. And suppose it's a block, we also do a laparoscopy and hysteroscopy, and there's a procedure called as cornual catheter where I can try to make the tubes open. Okay, it can happen that when I do laparoscopy, the tubes are actually patent. Okay, when I actually do a laparoscopy, the tubes are actually patent, and the tubes could actually be normal also on laparoscopy. Is it clear to all of you? So my point to all of you is that do not directly rush for IVF. Yes, is this understood to all of you? So I need to confirm. So this is a differential diagnosis, a very, very important. Clap if you have learned something new. That sir, I need to confirm whether it's actually a block or spasm, and laparoscopy will help me. Along with that, hysteroscopy will also help me, and I can try to remove the block. And if it is confirmed block, if it's a confirmed block, then I will have to proceed with IVF. Is it clear to all of you? So what is the main master chart for all of you, or what is the master flow chart for all of you? That if the HSG is showing a block, do not directly go for IVF. No, if the HSG is showing a block, you need to confirm it with a laparoscopy. Laparoscopy is the gold standard and confirmatory. If on laparoscopy the tubes are normal, excellent, they can conceive. If the tubes on laparoscopy are also blocked, and you try your best to remove the blockage, but if you can't, if it fails, then we proceed for IVF. 10 thumbs up if all of you understood this. Because if the tubes are blocked, okay, when both the tubes are blocked, the only option is to go in for IVF. Okay, IUI cannot work. Yes, can I get 10 thumbs up? So just because if HSG is showing any pathology, do not directly jump. Is this understood to all of you? So I hope it's absolutely crystal clear. Very good. This is a very, so with this we discuss the HSG also, which is showing you bilateral cornual block. This is a bilateral block, but it could also be a spasm, which is temporary, and of course it's the cornual area. Okay, so when you get this picture, do not directly jump to IVF. IUI will not work. Confirm the findings by hysterolaparoscopy and then proceed for the further management. Is this understood to all of you? Yes. Moving on. Now coming to IUI. Yes. Anybody? IUI, artificial insemination with husband semen, indicated in all of the following scenario except very simple, straightforward MCQ. Even if you don't know what is IUI, I'll explain to you in a minute. but anybody, can you tell me what it is? Yes, anybody? No, 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 not C, not C. Okay. Yes, D. Very good, Hassan, Roy, Salini, all of you. Okay. So all of you, please pay attention. Okay. What is this scenario? What is IUI? And IUI is done for what indications, and what is this? Can anybody tell me what is azoospermia? Azoospermia means zero sperm count, zero, absolutely zero. तो उसमें क्या करेंगे? I'll tell you in a minute. So all of you, please pay attention. What is IUI? In IUI, okay. So all of you, this is the uterus, this is the cervix, this is the vagina, and this is the fallopian tube. Okay. Now at the time of this is the ovary. At the time of ovulation, the egg will come inside the fallopian tube. Yes or no? Yes. Now what is done in IUI? Normally the normal sperm count, anybody, normal sperm count is, they say, more than 15 or more than 16 million per ml. Okay. Normal sperm count, anybody, normal sperm count more than 16 million per ml or more than 15 million per ml, that's okay. Okay. So if the sperm count is low, 5 million, 7 million, 10 million, then what is done in IUI? Any idea? Or if the speed, so either, when do I use IUI? Sir, when the count is less or when the sperm speed is also low. So I can use it for oligospermia as well as asthenospermia, but the count should be somewhere between 5 to 15 million per ml. Is this understood to all of you? For IUI to be successful, remember students, that the sperm count of the male partner should be somewhere between 5 to 15 million per ml. तो अभी IUI में क्या करते हैं? We take the semen sample of the male in the laboratory and I wash it, I prepare it, all the kachra I remove, all the dead sperms are removed, all the lula langda sperms are removed, and we bypass the cervix and with a small catheter directly push the semen sample inside the uterus, which is IUI. Is this understood? So I am bypassing the cervix. Is it clear to all of you? So anywhere else can I use it? Yes, sir. Is this understood now to all of you? Okay, sir, this procedure is absolutely good for oligospermia count of 10 million. Yes, had this been 1 million, half million, then IUI cannot work. Remember, for IUI, sperm count should be between 5 to 15 million per ml. That is the requisite. So 10 million में IUI कर सकते हैं? Yes, sir. Of course, I am bypassing the cervix and directly putting the sperm inside. So for cervical factor also, we can do the IUI. And when there is erectile dysfunction, please understand, it is not the treatment for erectile dysfunction. For erectile dysfunction, of course, we give sildenafil, Viagra, tadalafil, all that can be tried. But for the infertility point of view, like in the laboratory with masturbation, the count is 100 million. At the time of sex, the person is not getting erection. Then to treat the infertility component of impotency also, we can take the sperms and put it inside the uterus. Okay, Shipra beta, that we'll discuss in this. Yes, we'll discuss in the actual classes, because the sperm count is very low, then the patient requires IVF. Okay, when the sperm count, if they give you in the exam that what is the option if a male has a count, so you need to come back and Shipra listen to my detailed classes, and if a patient has count of 1 million, 0.5 million, then IUI will not work. They will IUI cross. IUI will not work. They will have to go for IVF. Okay, is it clear to all of you? Yes. So this is the yeah. Beta ICSI Still lesser. ICSI when the count is, yes, very, very low, very good. They have to go for ICSI, very good, Johnny. Okay, so the answer is azoospermia. Why the answer is azoospermia? Because the sperm count is 0. What will I do for azoospermia, all of you? Why IUI cannot work? What will I do for azoospermia? Is this understood, all of it? It's a difficult MCQ for the INI-CET. So answer is option number D. Because for ABC, for all ABC, IUI will work. Okay. So can anybody tell me why is option number D is the answer? Because that is what I told you. Okay, sir, for IUI with the husband sperm, the count should be between 5 to 15 million per ml. Azoospermia में तो 0 count है, तो क्या करना पड़ेगा azoospermia में? Yes, sir, azoospermia will require that Wiki Donor movie had come. Okay, azoospermia में क्या करना पड़ेगा? You will have to do IUI with the donor sperms. Okay, what Wiki Donor movie had come, because husband count is 0. Or if the testes are producing sperms, then we can think of doing ICSI. Okay, all this we discuss in our detailed classes in IVF and ICSI topic, that ICSI is possible provided we are able to retrieve the sperms from the testes. Okay, is it clear to all of you? Yes, can I get 10 thumbs up? Is it understood to all of you? So sir, simple, sir, IUI, remember tubes have to be, and this all of you look on the board, that when I told you over here that in IUI we put the sperms inside the uterus, then the sperms have to go above on their own, and even egg has to come from here, so the tubes also have to be normal. So fallopian tubes should be normal. Please understand this. Is this understood to all of you? IUI, whether I do it husband sperm or donor sperms, IUI के लिए the fallopian tubes have to be patent or have to be normal. Then only yes, Prathamesh, the brief course will be starting very soon. Yes, very good, Adhoy Crystal there, very good, that's it. Okay, so fallopian tubes have to be normal, then only I can think of IUI. Oligospermia में करेंगे, impotency में करेंगे, antisperm antibody cervical mucus में करेंगे, azoospermia will require IUI donor or they will require ICSI. Is it clear to all of you? Yes, Roy, I told you, asthenospermia also IUI can be done. Yes, very good. Asthenospermia IUI can be done. Okay, please tell me the preference. Some students want me to use a thick pen, some thin pen. So please let me know which pen should I use. I don't mind using both of them. So let me know in the chat box whether you are okay with a thick pen like this or you want a thin pen. Please let me know. If we can get a consensus, we'll use that kind of a pen. Okay, yes. So moving on now. So this is the second topic. Okay, now topic number 2. First topic over. Okay, so first topic was of our infertility. Discuss 2 MCQs, male factor, female factor. Topic number 2. Okay, patient has dyspareunia, dysmenorrhea, infertility, PV. Thick is good, very good. Okay, thick is good, very good. Thick is, yes. Okay, retroverted uterus, nodularity, pouch of Douglas, clinical case-based MCQ. Please tell me your diagnosis. Excellent, all of you, excellent. This is, okay, please pay attention, this is our classical thing, that whenever we have got DID, what I tell my student, DID is not dance India dance, but yes, DID. What is DID? Which is in the question paper. That's a dyspareunia, painful intercourse, dysmenorrhea, pain during periods, and infertility. This symptoms given in the exam, think of endometriosis. Is this understood to all of you? Along with this, remember the classical PV finding that the uterus is retroverted along with nodularity. Why does the uterus become retroverted? Anybody? Uterus becomes retroverted because of adhesions in the pouch of Douglas. So all of you, this is the urinary bladder. This is the, normally the uterus is anteverted. Okay, this what I have drawn is a anteverted uterus. UB I am writing is, UB is urinary bladder. Okay, Okay, so in endometriosis there's going to be lots of adhesions in the pelvis, and that is going to cause the uterus to become retroverted. What will happen is that all these adhesions will push the uterus back, and the uterus will become retroverted, and because of the adhesions the mobility is going to be affected. So it is called as fixed retroverted uterus. If you see this again in the question paper, think of one and only one: endometriosis. Is this understood to all of you? Fixed retroverted uterus, nodularity felt, all that. And what is the investigation of choice? HSG, no point. Hysteroscopy to no role only. We'll discuss a question on hysteroscopy. Hysteroscopy is to look at the cavity of the uterus. Okay, all of you? Yes. And again sonography में क्या दिखेगा? Anybody? The next best investigation. Answer all of you: laparoscopy. Very good. All those who said option number B. Anybody? What will I see on sonography? Laparoscopy, what will I see? What will I see on sonography? Laparoscopy is the investigation of choice. Investigation of choice, laparoscopy. Why? Because it can make diagnosis as well as treatment. चलो, what will I do if thickness किसका बेटा रामेश्वर? Okay, so yes, a transvaginal sonography on this patient. Yes, chocolate cyst. Okay, because endometriosis में होता है chocolate cyst, so that's the only component. But all patients don't have a chocolate cyst. Is it understood to all of you? Endometriosis, chocolate cyst is the only thing which I can see on sonography. Otherwise, rest all. Anybody? What do I see on laparoscopy? Anybody? क्या दिखता है laparoscopy में? What is laparoscopy? Laparoscopy is laparoscopy में I put in a telescope into the abdominal cavity. Okay, we put in a telescope into the abdominal cavity, and what will I see? This again an MCQ. Laparoscopy findings in a patient of HSG. Sorry, in a patient of endometriosis. Black spots, very good Appu. क्या बोलेंगे उसको? So what is better name? So in we can get, first of all, we can get a chocolate cyst. Okay, so in the ovaries, yes, I will get a chocolate color cyst. Okay, we don't have red brown, but yes, so this will get a chocolate cyst. Okay, what else? Yes, you get red lesions, red raspberry, you get fruit salad, all my, okay, blueberry. Yes, gunpowder, you get blueberry lesions. So all this I cannot see on ultrasonography. Seeing is believing. Okay, purple raspberry, blueberry lesions, all that you will get. Okay, so all of you, is it understood to all my dear students that we will get all this, and also you will get adhesions in the pouch of Douglas. So blueberry, and of course black also, powder burnt spots. Okay, black color ka, it's called gunpowder or powder burnt spots. Okay, and blueberry and red raspberry and purple raspberry, and yes, red lesion, very good, all of you correct. So all this can only be seen on laparoscopy, and laparoscopy is also useful for the simultaneous treatment and the surgery. Is it clear to all of you? I can clear all this, and we can burn the endometriotic implant. So topic number 2 over endometriosis investigations. Laparoscopy also helps in the treatment, and laparoscopy mein I can break all the adhesions. Okay, laparoscopy we can break the adhesions, remove the chocolate cyst, and burn. We can do electrocoagulation. Okay, we can burn the laparoscopic lesions. Okay, with a cautery you just burn it. Okay, it's called electrofulguration or electrocoagulation of the endometriotic implants. Yes, anybody? टॉपिक नंबर 3 10 करना है 1.5 घंटे में. Half an hour over, 1 hour to go. Yes, patient wants MTP 45 days. What do you think is the best plan? D wrong, wrong, D wrong, D wrong, John Wick C. Okay, A, B, C, D. Total confusion. C. Very good. Nikki C. Shipra B. Okay. So first of all, the MTP by the medicines. Okay, medicines. What are the medicines until how many days? Okay, so isn't it a confusing MCQ? And yes, you are going to make this mistake in the exam. Now don't make it. Point number one, the MTP is allowed with the medicines up to how many weeks? This medicine, by medicine I mean mifepristone and misoprostol. Okay, anybody? Mifepristone and then misoprostol. Up to how many days of pregnancy will this medical abortion work? Overall MTP we are not discussing, we are discussing only medical method. Overall MTP विक्रांत 8 वीक्स थोड़ा बेटर करेंगे, थोड़ा और करेंगे, और बढ़ाइए. No, 10 to 12 नहीं बेटा. Okay, so up to 9 weeks. No बेटा जीतू. Okay, 10 weeks के बाद I have to do suction evacuation. Is it clear? Yeah, first trimester cut. Very good Vikrant. Okay, so please understand, all of you. Please understand that up to 9 weeks or 63 days. 63 days from LMP, because 9 sevens are 63. We can go for the MTP kit. Okay, which is the Mifi plus Miso. Is it understood to all of you? Can anybody tell me what will I do? Yes, Vikrant correct, Jagan, A Khan, Kumari Beauty, and this Mahmudul Hassan given the answer. Very good. That if the pregnancy is 10 weeks, 11 weeks, 12 weeks, what do I do? Then I will go for suction evacuation, or also called as MVA, manual vacuum aspiration. Very good all of you, excellent all of you. Okay, so याद रखना कि 10 weeks, 11 weeks, 12 weeks है, so compulsory admit the patient and do a suction evacuation, or also called as dilatation evacuation. Okay, it's also called as dilatation and evacuation. Okay, yes, so now please remember this, all of you, please don't make a mistake in this. I repeat, for God's sake, this is, always remember that it is mifepristone first you need to prime the cervix and the uterus to meso. Directly meso you never give, always remember Mifi first. What is Mifi? Sir, Mifi is a anti-progestogen. It blocks the progesterone, so the pregnancy stops growing. Okay, it's an anti-progesterogenic action, so it stops the pregnancy from growing further, because it causes luteolysis, it causes the corpus luteum को damage. Basically anti-progesterogenic action, and it yes, Vikrant, you can do that also, perfectly correct. दोनों MI, लेकिन F comes before and S comes afterwards. Okay, so alphabetically you can remember. Yes, very good. So there is a single tablet, it's an anti-progestogen. It stops the pregnancy from growing further and prepares the uterus and cervix for the action of misoprost. Action is better, and this is 200 milligram single tablet. So all of you know कि option B out, because option B में meso first है. Okay, option D also out. Why option D out? Because here also meso is first, so दो option out हो गया. Is it clear? B and D out, and the misoprostol is a single tablet of 200 milligrams, and then mifepristone is a single tablet of 200 milligrams, and then I have got misoprostol. What is misoprostol? PGE1, prostaglandin E1. Each tablet is 200 microgram. Is this understood to all of you? Okay, is this understood to all of you? So please don't make a mistake in this, that sir, misoprostol is 200 microgram a single tablet, and into 4, so total is 800 microgram. Okay, which we give it vaginally. Okay, after 48 hours. Is this understood to all of you? Is it understood to all of you? So I'll just quickly give you the entire regimen. Lots of MCQs can come on this. On day 1, always one more very important, rule out ectopic pregnancy before giving MTP. Okay, you cannot always assume that it's an intrauterine pregnancy. Is it clear to all of you students? I need to rule out ectopic pregnancy, confirm it's an intrauterine pregnancy. So on day 1, when the patient comes to you, mifepristone is given 200 milligram, and after 48 hours on day 3, I give misoprostol 800 micrograms. 800 micrograms, we give it vaginally, that's the textbook thing, or we can also give oral sublingual. But if you want to give oral and sublingual, then you just split it, 400 or after some time 400 can be given sublingual also. Okay, is it clear to all of you? 400 sublingual, and after another 12 hours another 400 sublingual, because directly 800 sublingual, lot of nausea, vomiting, loose motions, all that. But remember, the total dose is 800 microgram. Okay, is it clear to all of you? So 48 hours gap, and that is our answer. That, sir, all those who had said option number C, sir, mifepristone 200 milligram and misoprostol 800 microgram after 48 hours. Okay, no beta, oral 1000 not required beta. Packet में 4 ही आते हैं. Okay, Vikrant, packet will be like this only. This is exactly the kit you have to remember. There are only 4 tablets. There are 4 tablets, so 800 ही होगा. Orally also, if you want to give, you give 800. Okay, 400 plus 400. 400 first, another 400. Okay. Yeah. You understood to all of you? Yes, so 800 microgram. Okay, and anybody after this, what is the one more precaution you need to give to the, what is the one more instruction you need to give to the patient? Patient came to you for MTP medicines given. What else? 2 important things what you need to discuss with the patient. Chalo, everybody, after MTP, what 2 things we need to watch for? Bleeding, of course. So she will start bleeding, there will be pain, crampy pain, pregnancy will come out. Yes, abortion will happen, bleeding will start. After that, what? Yes. How do I know my treatment is successful? What needs to be done, and what else? Bleeding will happen, of course. The bleeding is going to happen. She's going to pass. Yes, Abhishek, very good. That generally after 14 days, after 2 weeks, but anytime before, you should ideally do a ultrasonography to make sure that there are no retained products of conception, RPOC, because the tablets can also the success. If they ask you what is the success of this, anybody? One more MCQ. Okay, after 2 weeks we need to do ultrasonography and also then discuss about contraception. Yes or no? Your MTP treatment is incomplete if you only give MTP. No, as a doctor your job is to give MTP and also contraception advice, because she cannot keep on coming back to you. Now suppose if I ask you the success of this, okay, so ultrasonography should be done. If I ask you success is 80%, 70%, 96 to 98% and 100%. Chalo, A, B, C, D. What is the success rate of Mifi plus misoprostol? Yes, very good. 80-70 नहीं होता है. Textbooks mention 96. In my practice, we are getting almost 98 to 99%. Of course, nothing in the world is 100%. 100% नहीं होता है, but it is an excellent method in the success rate. That means 98-99% patients will completely evacuate, and very few will require a check curettage or whatever. Yes. Very good, all of you. Yes. New MCQ, something very, very important. Next, MTP Act 2021. Now MTP is allowed till dash weeks of gestation. Anybody? Yes, special reason. Very good, all of you. So please understand, all of you, that perfectly correct, all of you, that MTP was allowed only till 20 weeks of gestation. 20 is the old answer. Now it is till 24 weeks. But for which indication? So option C is the answer. Okay, all of you, this MCQ expected for sure. So 20 to 24 weeks, what extension has been done? Is till what weeks? Is for what indications? Very good. Rameshwar Nayak and Appu, that sir, if the baby, okay, if the fetus has got some, yeah, we are going to discuss that. Okay, to save the life of the mother, it can be done anytime. Okay, Samoi Maria baby. Okay, no. Okay, so point number one, why this 20 to 24 weeks extension is done is, this is for very good. There are certain fetal anomalies which are not compatible with life, and of course if there is a sexual assault victim or rape or special cases, matlab suppose there is a divorce or something, there are some special categories, like suppose at 21 22 weeks the husband dies, or there is a divorce happening or something, okay, or rape victim or sexual assault victim, then up to 24 weeks. Remember the important point. Yes, so fetal anomalies which are not compatible with life, these are the only cases where, yes, very good, that's the right way to put it, vulnerable females. Okay, but the important point I want to remember, all of you, is that there is a clause called as failure of contraception. Okay, for failure of contraception, it is still only till 20 weeks. Is this understood to all of you? This is very important exception to the rule. Failure of contraception is the most common reason why MTP is done. If they ask you today, maximum MTP, they ask you which is the most common reason why MTP is done. Okay, if we give you 4 reasons, suppose option A, rape, option B, fetal anomaly, option C, maternal health is at risk, okay, and failure of contraception. Can anybody tell me which is the most common indication or most common reason why we do MTP today? Is it understood to all of you? Now tell me the answer. So sir, fetal anomaly of course happens, but fetal anomaly rare. Again, rape cases and pregnancy out of rape and all that, rare. Maternal health, rare, not as common. This is the answer. Majority MTP is what we do today is because of failure of contraception. Is understood to all of you? That's the most common reason. So for this reason, it is only still till 20 weeks of gestation. Is it clear to all of you? So please keep in mind that if the question is that MTP is allowed till 24 weeks, but for failure of contraception, I'm writing FC. FC matlab failure of contraception is still only till 20 weeks. Okay, moving on to the next MCQ. Topic number prolapse ka topic. Topic number 4. Topic number 4. Fothergill's repair. Fothergill's surgery किसके लिए करते थे? Okay, so what is the Fothergill surgery? When do I do Fothergill surgery and for what? Okay, so Fothergill's repair, and anybody you have to tell me what is the main step of this surgery? What was the main step in Fothergill surgery? So Fothergill surgery was done, it is not routinely done nowadays. It's outdated. Okay, that is for Fothergill repair is for what? Fothergill repair for young patients. Okay, so for young patients, cervical surgery, and one more beta, one more. Yes, Rameshwar, can you tell me a better name for that? Widen cervical opening matlab kya? That is what my students should know, the perfect word. Okay, so young patients of prolapse, it was a proposed surgery. The main step is cervical amputation. In Fothergill's repair, what is done is that we will amputate the cervix, we chop off the cervix. Okay, yes, very good, Mamadul. It's also called as Manchester operation. Very good, caffeine. Cervical amputation is the main word. तो क्या होता है, what can happen, either cervix can become too tight and there could be stenosis, yes, but what can happen, mainly cervical incompetence. And we will discuss in our actual classes that when there is cervical incompetence, it will always cause abortion in the second trimester and never in the first trimester. Is this understood to all of you? I repeat, sir, Fothergill's repair or Fothergill's surgery would lead to development of cervical incompetence, and that would lead to miscarriage in the second trimester. Is this understood? And therefore this is the answer, because it is question is asked to you except. But yes, the cervix, I told you cervix can open up early, so preterm labor can happen, cervical dystocia can happen. Cervical dystocia means during labor. What is the meaning of cervical dystocia? So uterus is contracting, cervix fails to open, cervix does not dilate. Okay, other thing which can happen is infertility. Okay, patients can also not able to conceive also because cervix becomes too tight. Cervical stenosis bhi hota hai. Okay, so either cervix becomes too tight or cervix becomes too loose. Cervix too tight, stenosis, infertility. Cervix too loose, preterm labor, PROM, and second trimester miscarriage and incompetence. Anybody? What are? So and therefore Fothergill is hardly ever done or no longer done. Anybody? What are the what are the causes of abortion in the first trimester? Anybody? First trimester abortion, what are the causes? The first trimester abortion causes mainly are chromosomal and genetic. Most common, if they ask you, genetic causes. Yes, genetic abnormality in the fetus is the most common cause. Okay, so remember, Fothergill's surgery is not routinely done nowadays because it has got so many complications. Yes, anybody? Again, a very, very important MCQ which could come in the exam. Decubitus ulcer. Beta, contraception failure? No, beta. Ha, Prathamesh, so you are confusing between abortion and MTP. Okay, MTP is when you are willfully terminating pregnancy. Yes, that is it. Here we are talking about miscarriage. Okay, is it clear, beta? Don't get confused. When I'm asking you what are the complication of first trimester abortion, this is miscarriage. Usme genetic causes. These are spontaneous. Is it clear, Prathamesh? Tell me yes. So please, for God's sake, students, don't get confused. Okay. We say loosely abortion. MTP is different, where you are willful terminating, and abortion is different. Abortion or miscarriage. Spontaneous abortion. Here the most common cause is genetic causes in the first trimester. Is it clear to all of you? Yes. MTP, most common reason to perform MTP, failure of contract. Yes. So be coming back to this. Yes, very good. Decubitus ulcer is an ulcer which is seen mainly in 3rd and 4th degree prolapse only. It's because of the vascular congestion. It's an ulcer on the prolapse part of the cervix, and you don't do laser. Yes, you have to do packing, but you don't pack with H2O2 and acetic acid. Always it is packed with glycerine and acriflavine. Glycerine is a hygroscopic agent. What will glycerine do? So it will decrease the edema. Okay, it will decrease the edema. And acriflavine is a yellow color antiseptic. It's a dye. Okay, acriflavine is a yellow color dye. Okay, remember students, a yellow dye. So what you do is you take a tampon. A tampon is taken and in a bowl is taken, we put glycerin, we put acryflavin, we mix it, and a tampon is dipped in it and you put it inside. So that's called packing with glycerin acryflavin. It has got antiseptic property. It helps in rapid healing of the ulcer or abscession. Yes, beta Appu Hariharan, friction was the old theory. Okay, friction was the old theory, Appu. Venous stasis and venous congestion is the latest theory. Okay, Appu. So that's what I said. Vascular theory is got now more friction. So best answer you say venous stasis. Caffeine pessary can also be done, but pessary will only put the uterus cervix inside. Healing of the ulcer के लिए acryflavin is required. Okay, is it clear? So only repositing with pessary, not the best option. Okay, is it clear? Caffeine, tell me yes. Okay, so glycerin is a decreases the edema. Acryflavin is a dye which helps in antiseptic property. Yes. Topic number 5. Topic number 5. Halfway through. Okay, exactly 30-40 minutes more. Okay, stay right till the end. It's a 1.5 hours class, 6 to 7:30. Okay, 6 to 7:30. Topic number 5. Oncology and fibroids and topic coming up. Yes. What have I got? Heavy menstrual bleeding. So the topic is menorrhagia. Menorrhagia. What have I got? We have got a no Samu Maria baby, no estrogen. Estrogen will worsen the condition. Yes, menorrhagia topic very good. We have got heavy menstrual bleeding in a 32-year-old, and for some reason we did a biopsy and it is showing simple hyperplasia. Simple hyperplasia, but the important point, it is a very young patient, 32. At the age of 32, you do not remove the uterus, you will go to jail. I mean jail matlab ke you are not supposed to remove the uterus at 32 age, and that simple hyperplasia does not require removing the uterus. Okay, estrogen to never. Estrogen is going to worsen the hyperplasia. Hyperplasia itself is because of estrogen excess. Okay, what is required to counter the estrogen? Progesterone. POP मतलब progesterone only pill होगा या basically progesterone is the answer. So when I have got a hyperplasia, remember this, and it is a young patient given in the MCQ, the answer is progesterone. Is this understood to all of you? So POP or a progesterone only pill works very well. And again, hysterectomy never, and you don't do a Verdham hysterectomy. When you do Verdhams, we'll discuss that later also. Okay, so progesterone is the answer because hyperplasia can revert back. Okay, hyperplasia is a reversible condition. Hyperplasia is estrogen excess. So progesterone is given to counteract this estrogen which is more. Progesterone will reverse and hyperplasia can be reversed. Is it understood to all of you? Yes. But suppose if we tweak the question slightly, and now 48-year-old para 3 living 3. And we have got a patient who is now showing complex hyperplasia with atypia. Now what do I do? Again, OC pills we don't give. In 45 plus 40 plus we don't give OC pill just to control the menorrhagia. How many for option number 4? Verdham hysterectomy. How many for this? Verdham hysterectomy. Okay, so point number 1, the most appropriate management. Now, can anybody tell me complex hyperplasia with atypia, what is the chance of becoming cancer? So simple hyperplasia, only 1% chance of becoming cancer, and complex 1, 3, 8, 20 complex hyperplasia with atypia, the chance of becoming cancer 29 to 30%. Is this understood to all of you? Very good, Dr. Sumit. Okay. Very good, Rameshwar. Okay, so complex hyperplasia with a TPR, there is a 29 to 30% chance of progressing to CA endometrium, and therefore you do not wait and watch. And giving a LNG IUD or Mirena does not work when a TPR is present. Okay, so when I have a young patient who is having hyperplasia, we prefer to give progesterone therapy. But if there is a old patient, or if there is presence of a TPA, then better to go and do a simple hysterectomy. What is the meaning of simple hysterectomy? Like any other benign condition. Okay, please, the biggest mistake students make is moment they see this TPA word, many of them mark number 4. No, I will not do Verdheims. Verdheims is for actual cancer. Is this cancer? No sir, this is pre-malignant condition. Can I get 10 thumbs up? And therefore simple hysterectomy is the best answer, because family is already complete. She is 43, she is 48, parathelial living trend, besides it is complex hyperplasia with TPA. So simple hysterectomy. Is it understood to all of you? A Khan kya, no kya ho gaya? Is it clear to all of you? So please understand that simple hysterectomy is more than enough. Okay, don't go for Verdheim hysterectomy, because Verdheim hysterectomy is done for actual cancer. Hyperplasia is not cancer. Hyperplasia will convert into cancer in 29-30% cases. So here, when you have only hyperplasia, a normal simple hysterectomy, like a routine hysterectomy. Okay, just the uterus and the cervix comes out of the body. Okay, like any other benign condition. Yes, so that was our topic of menorrhagia. Very, very important. Yes, again the most important topic, primary amenorrhea. Every year entrance exam, this topic has to come. It will come. Take the last 10 years paper, last 15 years paper, and the topic of primary amenorrhea will be there. So I have got a patient of primary amenorrhea, breast well developed, absence of axillary pubic hair, lump, and ultrasonography, absent uterus. Now tell me all of you, what about Turner's syndrome? Is Turner's syndrome uterus absent? How is the uterus in Turner's syndrome? Why is Turner's syndrome not the answer? Turner's syndrome is not the answer because in Turner's syndrome the uterus is present. Uterus is present. It is small, chin 2, hypoplastic, underdeveloped, but yes, streak ovaries, very good, but a small or a rudimentary uterus, but it is not absent uterus. Similarly, Kalman syndrome, also uterus is present. Is this understood? So please students, don't make a mistake that in the exam you are going to get this combo pack or combo offer every year. Mark my words, even this NEET PG there was an MCQ that when you get primary amenorrhea with absent uterus, you will look at only 2 options. Whatever other 3-4, don't look at it only. What are the 2 options? Sir, either it is MRKH, Rokitansky, Mayer, Kushner-Hauser, Muranogenesis, or complete androgen insensitivity syndrome. Is this understood to all of you? Only 2 options, only 2 in the whole of OBGYN. Okay, and how to differentiate that? Sir, in RMKH syndrome there will be well developed axillary and pubic hair. Beta Swyer syndrome nahi beta. Okay, so okay, Swyer syndrome again uterus would be there. Okay, so androgen insensitivity is the answer. Why? Because absence of axillary and pubic hair. Is this understood to all of you? That what happens? All of you pay attention that in your RMKH, remember all the students in the classroom, including all the normal females, the axillary and the pubic hair, axillary and pubic hair is androgen dependent. You will remember this. Will you remember this? It's our axillary pubic hair is androgen dependent. RMKH is a normal female. They will have well developed axillary pubic hair, and in this column, complete androgen insensitivity, axillary and pubic hair will be absent. That is the clincher. That is the clincher. Yes, we are going to discuss that in a minute also, Sandeep Sarkar. Give me a minute. Okay, so look at the axillary and pubic hair in the patient. Breast will be developed in both of them. Don't make a difference. That is not a difference. Okay, if you look at breast, okay, breast development, यहाँ पे भी टिक टिक, यहाँ पे भी टिक टिक, well developed. Okay, is it clear to all of you? We explain all this in our actual classes, and very good. RMKH is 46XX and AIS is 46XY. Okay, axillary pubic hair is what will help you determine what is the scenario. Axillary pubic hair present है तो mark RMKH, axillary pubic hair absent है तो mark your CAIS. And anybody मेरा client factor is males, okay, so that a pediatrician, tall unicorn males, okay, Khan. And abhi ye bata do, what is this? Can anybody tell me? So here, because of this absence of axillary and pubic hair, our diagnosis is androgen insensitivity. And what is this lump in the inguinal region? Very, very important. What is the lump in the inguinal region? Yes, that is the undescended testes. Okay, the testes which have got undescended, and you will remove those testes because of risk of malignancy. Okay, so undescended testes because of risk of gonadoblastoma or some. Very good, Dr. Sumit. Okay, is it clear to all of you? So when you get a patient of primary amenorrhea, absent uterus, absence of axillary pubic hair and lump in the inguinal region, that is the undescended testes, it is another name is testicular feminization syndrome. Naam mein answer, testes but rest all feminine. Okay, so androgen insensitivity syndrome is the answer. AIS only, yes, it is androgen insensitivity syndrome or testicular feminization. Okay, yes. And suppose in the question paper if they tell you that there is axillary pubic hair well developed, then you will mark this. Okay, suppose if the question is that there is well developed axillary pubic hair, then mark this Turner's, and this is clear cut out. Okay, Kallman syndrome will be anosmia. Anosmia will be there. Okay, is it clear to all of you? One more new thing, very, very important. Can anybody tell me? So remember the students, primary amenorrhea, absent uterus, only two things to be kept in mind. Now, can anybody tell me the new definition of primary amenorrhea? New definition. New मतलब के age criteria. $10 years, 13 years, 14 years, 16 years. If I say primary amenorrhea and no secondary sexual characters, no, in absence, there is no secondary sexual characters. Now what is the answer? Yes, 13. Remember 14 was the old criteria, that in absence of secondary sexual characters, no menses or absence of menses till the age of 14 tha, the new is 13. Clap if you have learned something new. Okay, so yes, Sandeep Sarkar, 13 and 15, very good. Healthy med talk, no, that has been changed. Okay, 14 years is changed. Okay, is it clear to all of you? So in presence. Okay, so is it clear to all of you? So we say that there is no menses. Okay, menses has not come, but If I'm writing secondary sexual characters, okay, SCC is my short form. If secondary sexual characters are present, absent, 13 years, no menses, and here 15 years. Okay. Yes, very good. Topic number 7, hot favorite, contraception. Every year the MCQ comes. Contraception करेंगे, फिर फाइब्रॉइड करेंगे, और ऑन्कोलॉजी कैंसर इन द नेक्स्ट 30 minutes, 26 minutes more, all of you. Yes. 30-year-old, para 1, living 1. What is the most suitable for this? Okay, K stroke C stroke O matlab known case of, okay, the standard short form, known case of complicated migraine. So what have I got? She has got a patient who has dysmenorrhea. She wants contraception for 6 months. Obviously, very good, all of you. She is only para 1, living 1. She wants contraception for 6 months. So tubal ligation is out. Yes, tubal ligation is out because she wants a temporary method. This is a permanent method, and she is only 1 baby. Now can anybody tell me why will I not give OC pills? OC pills because, sir, complicated migraine, absolute contraindication. For which condition? Complicated migraine मतलब migraine with aura. Okay, so remember, migraine with aura, migraine headaches with aura. OC pills will worsen. OC pills, absolute contraindication. CI. Okay, is it clear to all of you? Any other absolute contra? Suppose you have got severe hypertension, severe diabetes, then if you have got liver disease, okay, if you have got liver disease, heart disease, all that I cannot give OC pills. तो OC pills भी out हो गया. And copper T is why? Because uterus is having multiple fibroids and patient has got dysmenorrhea. Okay. Yes, very good. DVT, thromboembolism, Dr. Sumit, correct. Caffeine, correct. Smoking beta, again you have to be very clear. Mild smoking, dumb. Okay, dumb. Mild smoking is allowed. Matlab few cigarettes in a day, OC pills can be given. Yes, we will have to keep this in mind. And sir, when there are multiple fibroids, see what is going to happen. So this is the uterus. One fibroid is here, one fibroid is here, one fibroid could be here, one fibroid could be here. What is happening? The cavity is distorted. Look at the cavity of this patient. So the cavity is distorted. The cavity is a problem. So cavity is not normal. So copper T will not fit properly. Okay, copper T will not fit properly. So copper T भी out कर देंगे. Very good. Condoms, though high failure rate, it has got high failure rate. That is the most suitable for this patient. Normally we don't advise condoms because it got the one of the highest failure rates. But ये patient में that is the only suitable option left. Okay. Yes. Chronic smoker more than 35 years. Yes, very good. That is the thing. Shubham, both age more than 35, more than 20 cigarettes per day. Okay. So that is how things are. Yeah. Okay. Now, next MCQ. Mrs. XYZ, since 1 month, comes for contraception advice, wants to delay pregnancy for 1 year. Both partners healthy. What is the best advice which you can give her? Yes. So now here condoms will decrease the sexual pleasure and very high failure rate, 4 to 14%. So we newly married couple, we don't say condoms. Very good. Vasectomy obviously is out of question. Okay, it's a permanent method. And IUD, again I will avoid. IUD, why will I avoid? Because the patient is nulliparous. Okay, so in a nulliparous patient, because they've written that newly married only since 1 month, so never got any pregnancy, nulliparous, and both are healthy. Therefore, OC pills, by healthy I mean that she does not have any migraine headaches, or she does not have any thromboembolism DVT. So OC pills are very good and they can be used safely for 1 year. So newly married healthy couple. Okay, and remember, in IUCD you avoid in nulliparous. IUCD is best in which scenario? Sir, IUCD is best for spacer devices. Remember that, students. Okay, that when a patient, yes, when a patient has already got one baby and now she is waiting for another baby, she wants 2 to 3 years gap, so then IUCD becomes the most suitable. Okay, so one baby patient already has, and now to wait for the second baby, 2 to 3 years gap, here IUCD is the best because it has got very low failure rate. It is long acting, reversible for spacing here, therefore they are called as spacer devices. Okay, is it clear to all of you? Yes. Moving on to topic number 8. Identify this instrument. No, beta, Sandeep, IUCD 10 years also. Sandeep Sarkar, which IUCD is for 10 years? Longest acting. Copper T 380. Government supply 10 years. Yes. Myrina for 5 years. Okay, Sandeep. Myrina is the LNG IUD. Myrina is LNG IUD. There is also multi-load 375. That is also for 5 years. Very good. Now what is this instrument? नाम में ही आंसर है. Yes, very good, Saumi Maria. Excellent. That, sir, this is a Boni's myomectomy clamp, and therefore the answer is myomectomy. It is when you do open, and it's a open surgery. Open matlab ke laparotomy. Okay, when a laparotomy is done, very good. This is the instrument which is temporarily, basically what it does is that this part, it temporarily clamps the uterine arteries. Uterine artery clamp ho jata hai, so it will decrease the blood supply. It is not used for Wertheim's hysterectomy or radical hysterectomy, neither it is used in vaginal hysterectomy. It is only done in a laparotomy. If I have done open, open, then what is does it that this instrument we use, it is temporarily clamping the uterine artery, and it is going to decrease the blood loss. So the main purpose of this instrument is to decrease the intraoperative blood loss during myomectomy surgery. Is this understood to all of you? Is going to decrease the blood loss. Now the question comes, can you tell me 2 more techniques which can be done to decrease the blood loss? One is the use of Sir Boni's myomectomy clamp. Okay, so it's called Victor Boni tha. Okay, so Boni's, this is the myomectomy clamp. Yeah, Shiphu Mule Thalwa. Yes, one is this, others one. I'm telling you 2 other techniques. 2 other techniques which can be done. Very good. Compression, yes. We can go for uterine artery embolization can be given. And one is, yes, you can use a tourniquet. And other one, student, remember, vasopressin. vasopressin, not शुभम नहीं, वो नहीं, not magnetic है, okay, vasopressin injection. Okay, vasopressin is a drug which we give it into this. So vasopressin injection is vasoconstriction, so it can be given, it is injected, okay, vasopressin injection into the myoma bed. So suppose this is the huge fibroid, suppose this is the uterus, the huge fibroid, so I will inject the vasopressin and then you make a cut and then scoop, remove the fibroid. Okay, so it's a huge fibroid, then we give vasopressin. Okay, is it clear to all of you? Yes. And anybody also, what are the drugs, very important MCQ, what are the drugs which are available to decrease the size of the fibroid? Can anybody tell me 2-3 drugs to decrease the size of the fibroids? Trenexa, yes, Sumit, Trenexa, agree, Trenexa can be given. Yes, so GnRH analogs can be given. Very good. Progesterone only pills, POP can be given, or Mirena can be done. Very good. And what else? Yes, Ocipils, okay, can be given. And what else? What else? Yes, the new drug GnRH analogs, don't forget. And Ulipristal. Ulipristal is a newer drug. Don't make a mistake. Definitely this MCQ is coming. Ulipristal is a selective progesterone receptor modulator, SPRM. All the dose, all that we discuss in detail in the lecture class. Okay, so ulipristal acetate is a newer drug which can also be, is one of the drug to decrease the size of the fibroids. Yes, next MCQ, drug of choice for galactorrhea. Galactorrhea happens because for prolactin is high, so it is also called as hyperprolactinemia. And when the prolactin is high, anybody, what will it cause? And what are the causes of hyper? Okay, so whenever there is hyperprolactinemia, hyperprolactin, it will cause milky secretions from the breast and the nipples, so that's called as galactorrhea. And it also causes amenorrhea in the patient. So this combination, remember students, yes, very good, pituitary adenoma is the most common cause, but if this macro, other causes of hyperprolactinemia, stress, anxiety, okay, yes, so galactorrhea, it's also called as galactorrhea amenorrhea syndrome. Okay, yes, infertility ho sakta hai. Okay, and the causes are mainly your pituitary adenoma and your antipsychotic drugs. Okay, which drugs? Anybody, they ask you which drugs? So remember dopamine. Which drugs, anybody? If we tell you, which are the drugs which increase prolactin? Pharmac, drugs which cause increase in prolactin. Yes, so all your antis, yes, very good. So all your psychiatric medicines, okay, which is your risperidone, very good. Antipsychotic, okay, haloperidol, okay, chloropromazine, all that, yes, perfectly, because remember dopamine inhibits prolactin, so all the dopamine blockers, perfectly correct, all the dopamine blockers, specifically your antipsychiatric drug, which medicines are used, they're going to cause this. Okay, yes, antipsychotics, perfectly correct. Now metformin is for what? Metformin is for your insulin resistance in a patient of PCOS. PCOS is a very popular topic, but we didn't discuss it because we discussed many times in the past. Dopamine is not required. We're going to need dopamine blockers. So I have to choose between 1 and 3, and number 3 is the answer. Why? Cabergoline is the answer, much more than A. 1, 2, 3, 4, so C more than A. Option C more than option A. Anybody, why? Because remember cabergoline and bromocriptine. What is the another difference? Anybody? Why cabergoline is the answer? Okay, so answer to the MCQ option C. Drug of choice is cabergoline. So sir, yes, very good. Bromocriptine has got side effects and it is to be taken daily. Daily patient will have to take. Anybody? Yes, Shubham. And cabergoline. How do you take cabergoline? Any idea? How is cabergoline taken? Only once a week. So definitely better patient compliance, and therefore cabergoline is preferred over bromocriptine, and cabergoline less side effects. Okay, the side effects are also lesser, better patient compliance, only once a week. Yes, Swami Varia correct. 0.25 भी आता है, 0.25 mg or 0.5 mg is also available. We are talking of cabergoline. Okay, cabergoline is 0.25 mg or 0.5 mg once a week. You give it for at least 4 to 8 weeks. Yes, so that was topic number 9. And topic number 10. I have got a obese patient, 53-year-old, diabetes, hypertension, again heavy bleeding. Which is the most important cause that should be considered in this age group with the obesity, diabetes, hypertension? No, Dr. Sumit, no PCOS. Why? PCOS which population? PCOS में क्या होगा? Sir, acne, hirsutism, infertility, young patient generally. Yes, very good. All of you, Caffeine, John Wick, Dark Knight. Okay, Abhishek, Dev Panda, all of you. Yes. Okay, fibroid again. Fibroid mainly happens 30 to 40, 53 hai. Okay, old patient. And along with that, yes, fibroids ho sakta hai. I'm not saying no, but the most important cause that has to be considered. And again, remember, epithelial cancer will never cause. What are the symptoms of epithelial ovarian cancer? Epithelial ovarian cancer, what are the symptoms? So they are mainly having weight loss, non-specific. Okay, so remember students, epithelial ovarian cancer, epithelial cancer of the ovary, first prognosis, because they have got non-specific symptoms. Non-specific upper GI. Yes, along with adnexal mass, very good Dr. Shubham. But epithelial ovarian cancer, non-specific, dyspepsia, bloating, indigestion, acidity, acid reflux, all that. Okay. Upper GI symptoms they get. And then there is weight loss directly. They never have heavy menstrual bleeding or never. This mainly patient will have post-menopausal bleeding. If they tell you she is a post-menopausal lady also, 53. Okay. CA endometrium. Why? Because what is the triad? Anybody? Can anybody tell me what is the 3 things the patient is having? Obesity. Kya diya hai? Obese. Diabetes, hypertension. This is the classical obesity, hypertension and diabetes. This is the 3 risk factors for CA endometrium, and CA endometrium happens in the postmenopausal lady. Very good, Caffeine. Okay, CA endometrium happens in the lady who is, so any patient who is 50 plus, 60 plus age group, में this age group with obesity, hypertension, menstrual bleeding, heavy menstrual bleeding, you need to rule out this, and CA endometrium is the most important cause. Fibroid mainly after menopause, after 50 starts shrinking in size. Okay, so epithelial cancer will not cause any postmenopausal bleeding episodes. PCOS is a young patient with infertility and acne, and sudism generally 20-30-year-old girl. So CA endometrium. Okay, CA endometrium is the most important thing. And how do you rule out? Yes, you will have to compulsory do. What will I do for this patient? Anybody? What is the next step for this patient? इसमें क्या करोगे? So if they ask you what next, What next for this patient? Yes, endometrial thickness very good. So sonography के अलावा how do you confirm? Transvaginal, of course, yes. And what else? What else? Yes, absolutely correct. HPE is mandatory, all of you. Histopathological examination, you will have to do, either we will do a DNC or a hysteroscopy and biopsy, basically endometrial biopsy, because HPE से ही पता चलेगा I need to do this to rule out CA endometrium. Then staging and all that and treatment comes later. Yes, so HPE is mandatory. Okay, and we have got time for one more. Can anybody identify this image? What is it? This is the cuscus speculum. उसका edge है. What is being shown over here? Yeah, cervix दिख रहा है. Yes, what else? No, this is not liquid based cytology. What is being shown? So this is the cervix. Yes, this is the anterior lip, this is the posterior lip. So this is the cervix. And what is the overall picture like? Yes, very good. Shubham Gupta, very good. This is, the whole thing is looking green. Isn't it looking, the whole picture clearly on the screen also I can see, and the whole picture is green in color. So this is colposcopy. Don't make this mistake in the exam. Okay, colposcopy is done in this with the help of green filter, and green filter colposcopy we do. Colposcopy is for magnification. Then I apply acetic acid. Okay, so first I will apply acetic acid. We apply acetic acid and we take the biopsy from the acetocyte area. And anybody? Very good, caffeine. Yes, green filter is to see the blood vessels. Okay, the blood vessels, if you see end on, how are they going to look as? Anybody? Punctate pattern. Is it clear to all of you? Why? Because when the vessels, all of you, this vessels end on, okay, you will see the vessels end on, you will only see the this. Okay, so blood vessels are running like this, and when you see the blood vessels end on, that means samne se, you will see the punctate pattern. So basically the green filter, this is not liquid based cytology, this is not hysteroscopy. Hysteroscopy is inside the cavity. Perhaps में नहीं, colposcopy है. Colposcopy, green color filter is there, and you get this thing. Okay, so you get the green filter to see the vessels. Neovascularization. Neovascularization is best seen with green filter on colposcopy. Okay, so this is a colposcopy showing you the cervix. This MCQ very likely to be coming in the upcoming examination. Is this understood to all of you? So I hope all of you had a great time today. All the 10 topics, if you see, we have covered all of them. Okay, we have covered the topics of infertility, contraception, menorrhagia, fibroid, prolapse, oncology, all that. And please, 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 all of you, so all this MCQs is so many, I think more than 15 to 20 MCQs. MTP topic we covered, endoscopy, and even endometriosis topic also we covered, and we began with this HSG image also. Okay, so image based also. So that is our 10 gynac topics, MCQs related to that. I hope it was a very useful session to all of you, and do not forget tomorrow Saturday 8th, Okay, tomorrow also we are going to have all of you, please go to the Unacademy and check out the NEET PG Vitals to see my lectures, and mentor is the code to get the discount, and lots of batches are coming up, and tomorrow 8th April at 6 p.m. Okay, so I'm seeing all of you tomorrow at 6 p.m. for another fabulous discussion on the obstetric MCQ. Okay, so OBS MCQ, again 10 topics, T20. So as I told you, T20 we have divided into two, session 1, session 2. Okay, so today the first session, lots of around 14 around 14 to 15 MCQs have discussed in 10 topics, and tomorrow also 10 OBGYN topics. Yeah, okay, Dr. So the first session, excellent. Okay, please come regularly and better. Check out the NEET PG Vitals. I'm telling you, you're going to love it, and you'll thank me for the rest of your life, is my guarantee. Each and every MCQ in your exam will be from my lectures, is my guarantee. Check out the NEET PG Vitals. See the sample video. Take for the 3 months, 6 months package as soon as possible. Super entire 60-70 hours of top quality video lecture with all the latest MCQs. Okay, so bye bye. Best of luck. Thank you very much, all of you, for coming in today, and I see you tomorrow at the same time, 6 p.m. for the MCQs and obstetrics. Bye. Thank you very much.